So, welcome to this session of the Global Conference on Turning the COVID-19 Crisis into an Opportunity. What's next for social protection? Let me first just briefly introduce you to the topic of this session. Access to healthcare without hardship and income security in times of sickness are central objectives of social protection systems. The COVID-19 crisis highlighted the importance of having a strong social health protection system, articulating both access to health services for all and income support for people affected by the disease. As a response to the COVID-19 crisis, many countries have taken measures to enhance access to affordable healthcare and to close the gaps in social health protection. Many such measures could be expanded beyond the crisis, and they've encompassed enhancing financial protection against healthcare expenses, so quality financial protection, ensuring universality, continuity of coverage, integrating prevention, testing, and the treatment measures, expanding the scope of treatments and the way they are delivered, like with telemedicine, within the healthcare benefit packages, channeling additional fiscal resources into the health system, improving coordination in the health system, particularly with the private sector. The COVID-19 crisis exposed critical gaps also in a related benefit coverage, package, which is sickness benefits. Not so well known in Asia, for example, but critical in this response. Many numbers of workers have been left without sickness benefit coverage, including self-employed, workers in non-standard employment, and workers without paid sick leave. Were really one of the main gaps in this response. The roundtable will build on country experiences to highlight the key elements that supported these effective responses, highlighting particularly strong institutions and the existence of legal frameworks for rapid responses. It will also highlight gaps in social health protection coverage. Without further ado, I'd like to present the speakers. I hope we are all there. Mrs. Hee Chung Kang. She's a research fellow in the Healthcare Policy Research Department of the Korea Institute for Health and Social Affairs. She's been since 2003, and she served before as Director of Social Insurance Research Department. KIHASA is a national think tank that improves the quality of life for the Korean population by promoting the nation's health and welfare system. Through systematic research and evaluation. She has led different government research projects, including enhancing national health insurance coverage, developing an annual national healthcare quality and disparities report, national healthcare big data strategy. She's been a Korea delegate in the OECD Health Committee until 2019. Dr. Knut Lönnroth is professor of social medicine at the Department of Public Health Sciences at the Karolinska Institute, Stockholm in Sweden. He is director of the Center for Tuberculosis Research, and the WHO Collaboration Center on TB and Social Determinants, the Social Protection Action Research and Knowledge Sharing Network. He's been working for the Global Tuberculosis Program of WHO for 14 years. Dr. Nguyen Can Phuong is currently Vice Director of the Health Strategy and Policy Institute at the Ministry of Health in Vietnam. She is a leading health economist with more than 20 years of experience in health financing. She's got extensive experience in the health sector, having held many positions, and she's involved in several studies which provided evidence for developing important health policies in the country. Mr. I hope I pronounced the name correctly, Phik Sambo is Deputy Secretary General at the National Social Protection Council, the interministerial body that oversees the establishment of Cambodia's social protection system. And Mrs. Marielle Fegusa from the ILO. She's a technical advisor on social health protection in Vietnam, Myanmar, and Lagos with 15 years experience, also in Sub-Saharan Africa and Southeast Asia. And she's currently supporting the Connect facility on social health protection in Asia. Myself, I am based in Beijing, China. I'm the manager of the EU-China project on improving China's institutional capacity towards universal social protection. We will have 2 rounds of questions for debate. In each round of questions, I will ask the different speakers to address different topics. Each round is supposed to be 25 minutes. So I hope that we will be able to stick to time. And if we have time within those 25, I can take 1 or 2 questions from the chat box. So without further ado, let me start with the first discussion point. In looking at the experiences, Dr. Hichung experiences some technical problems. I hope you will resolve those. And welcome. The first discussion point is, what were the features of the social health protection system that helped respond to the COVID-19 crisis effectively? What lessons can we draw from them? Let me start with Mr. Sambo Phik, the General Secretariat of the National Social Protection Council in Cambodia. I think you have an interesting experience regarding the integration of cash transfers with health protection package. Can you tell us the experience of Cambodia?
Well, first of all, thank you. Thank you for having me today. In Cambodia, I think we are a bit lucky, I would say, because we have very few cases of the COVID so far, with no mortality rates, and most cases were exported from outside the country. So basically, we don't really have problem with the local outbreak, right? So, but although in the early days, from maybe I think March to May or something, the economy of the country was hitting quite substantially. So some employees, they were briefly suspended from the job, I would say, and then the government stepped in to make sure that as long as the company didn't declare bankruptcy, which most didn't, their employees still enjoy the health insurance entitlement without even paying the contribution. That is one intervention that the government made. And on top of that, in Cambodia, we also have another health protection scheme for the poor people. We call it the Health Equity Fund. The Health Equity Fund has expanded slightly its number of beneficiaries during this time because of the implementation of the COVID relief cash transfer program. Just to inform you a bit about this cash transfer relief program, to implement this immediately, the government has we had the ID pool identification to identify those poor households for many years already, right? But to implement this cash transfer relief, we we start implemented immediately the ID pool on demand, you know, to make sure to update the number of the people that are already poor, and also to update, you know, those who might fall into the poverty during this COVID crisis, right? So with this updating the data, we can see that a lot of people have been added into the scheme during this time. I think at least 600,000 people have been added to this, so they can get both the cash transfer relief together with the health protection, you know. Thank you.
Thank you. Just a clarification. You say 600,000 enrollees were suspended. Could you explain what happened?
Oh, you meant the suspension, or because there were two. The first one is about the suspended of the job of the employees, right? When the economy was hitting, then the business have been closed down a lot. Then of course the people have been suspended from the job, right? So they usually they pay the contribution through the company, and then when the company closed down, of course they don't pay the contribution to the health insurance fund anymore. But the government made sure that even though they don't pay the contribution, they still entitled to the benefits if they, you know, as long as the company didn't declare bankrupt. So, but if the company they declare bankrupt already, then we are sorry.
Okay,
but
no, I understand. Thank you. Thanks so much. I'd like to add now Dr. Nguyen Can Pong, if she's online.
Hello. Hello.
Hello.
Hello. Yeah.
Welcome.
Can you hear me? Can you hear me clearly?
Yes, yes.
Okay, that's good. Thank you.
So what was the experience of Vietnam regarding the key features that help you respond to the crisis?
In Vietnam, the social health insurance is the main health financing. We determine the health to achieve the universal health insurance to be the main financing to move towards to universal health coverage. Currently, the coverage of people with the social health insurance is 90%, with the very strong commitment and subsidy from the government to select the vulnerable group to be included in the social health insurance, such as the poor, the minor ethnicity, the elderly, and the children under 6. Currently, the most vulnerable group has been subsidized by government to be enrolled in the health insurance, social health insurance. So in Vietnam, we have the experience the COVID-19 for the first wave from the December to April, and then the second wave from the July 2020, and up to now we have so far 34 days. There's no case reported from community. So in generally, it can be said that Vietnam has fairly well control of COVID-19. In terms of the financing, the mobilization of the resources to respond to the pandemic, in Vietnam, according to the budgetary law, we have the reserve budget to respond to pandemic or any that disaster, national disaster, and the reserve fund was collected at the administrative level of, in the whole country, from the central, provincial, and district level, in accordance with the auto administrative level over the country. So in principle, the budget, the resource, financial resources to respond to pandemic is mainly from the government budget. However, in Vietnam, during the COVID-19, the government has the very decisive action and strategy to respond to COVID-19 at a very early stage. There's also policy to mobilize resources from the different sources to respond, to cope with the pandemic. We have the Vietnam have the mainly the four main strategy to cope with the pandemic. The first is detection and the testing of the target group, mainly the people at the entry point for the immigration people, and the people who have close contact with the detected cases. So that is a testing. The first one is testing policy strategy, and the second is isolation, tracing, case tracing for any case detected in community. We have to implement very strictly and promptly action to trace anyone who has contact at the different level with the case detected. That is the case tracing. And the third strategy is treatment, effectively treatment of the detected cases. Up to now, in Vietnam, it is reported that 90% of the detected cases has been recovered, only recovered. There's only, up to now, there's only 35 deaths reported totally. Mainly, though have the other diseases, severe diseases, are the very old people. And the fourth strategy is the isolation. So the isolation for the immigrated people, and as well as the people have close contact with the detected cases. So for those four action strategy and activity. So for the there's the government budget pay for the tracing, case tracing, for the treatment and testing and treatment for the non-health insurance people, and also for the cost of isolation. But for the from the social health insurance, it covers the cost of testing and treatment for those who have the health insurance. And during the treatment of the COVID-19, all the co-payment of health insurance were removed, was exempted. So people do not have to pay co-payment. So that is the how the social health insurance has been mobilized to cope with the COVID-19 in Vietnam.
Thank you so much. So really a focus and emphasis on a mix of funding modalities to cope with basically different healthcare needs, different healthcare services established, and also to make the treatment accessible to all populations, universal access using government and health insurance. Yes?
I just want to add one point that during the COVID-19, one of the impact to the access to the healthcare is very serious among the people having the chronic disease, neither hypertension, diabetes, or the HIV. So the health insurance, social health insurance, has been adjusted the regulation so that they allow the people to receive to come to the checkup and to receive the medicine, not monthly as before pandemic, but the people can receive the medicine maximum up to 3 months. So they can still maintain treatment during the pandemic.
Mm-hmm. Thank you so much. This addition on the responsiveness of the supply and adaptation, and also this, we often forget that this period meant also some added difficulties for the other patients outside those affected by COVID. Thank you. I hope Mrs. Hee Chung Kang can hear us, and she can now take the floor.
Okay.
Ms. Hee Chung Kang is a research fellow at the Korean Institute for Health and Social Affairs.
Thank you. Thank you for having me. Yes, I will go to the point. Basically, all Koreans are protected by two national schemes for their dignified lives. One is Basic Livelihood Security Program. The other is the Social Insurance Programs. Our social insurance programs are based on monthly based premium. Is including national pension, employment insurance, national health insurance, and industrial accident compensation insurance. So all of those kind of social insurance programs are having a role to respond to the COVID-19 pandemic. And if I say more specifically about our response, as already known, I can say shortly our response as well-coordinated cooperation. Is already very famous. Our government is showing well-coordinated cooperation among all parties from public, private, local government, and expert spheres. It's all under the umbrella of the government. And I think it was possible that we had already enough lessons from the MERS in 2015, and then we had already established well-organized social insurance systems. In relation to the immediate response to this pandemic, since the outbreak of COVID-19 in Korea early this year, in a swift way, we amended the related laws and made the test and treatment cost all covered by NHI program. Besides, the amendment allowed the government to give financial subsidies to employers or self-employed so that they are giving paid sick leave to their workers in quarantine or isolation, or in treatment without paid sick leave. So I think our approach is the way of merge NHI program and Basic Livelihood Security Program. As I already mentioned, besides people covered the social security system, there should be underprivileged workers who are not covered by this kind of social insurance system. So the government have utilized the existing emergency aid programs for them. So by the aid programs, if they apply for the immediate subsidy, the government could provide them income subsidy or healthcare cost subsidy, or the other utility cost also could be subsidized. Yes, that's
Thank
it.
you.
I will go on.
Sorry, did I interrupt you? You had finished?
Yes, it's okay.
Yes. Okay, thank you so much for this first round. Let me now give the floor to Dr. Lundroth. He will, in a way, your intervention, Dr. Kang, was a good transition since I hear that you were particularly, you focus also on issues of paid sick leave, the income compensation for those who were sick, which obviously it's an important complement to the subsidization of healthcare itself. And I think Dr. Lundroth will tell us a little bit more about some research on sickness benefits.
Thank you, Luis. Indeed, building on a few decades actually of research into both socioeconomic barriers to get into care for tuberculosis patients and the socioeconomic consequences of that disease. We've done quite a lot of work to identify gaps in systems, including for concerning income security when you're sick. Actually, last year, so before the COVID-19 pandemic, we decided to do a systematic review to relook what ILO has done a couple of times, namely the existence and the coverage of different social protection schemes, taking specific focus on income security and sickness benefit schemes. So this was very timely, and we published a paper just in March, and were able to sort of update some of the background to reflect on its relevance for the COVID-19 pandemic. So this is not, I would say, so much about the features that have helped the response, but more the gaps that, Luis, that you were mentioning in the beginning, that actually have been problematic in terms of responding to the pandemic. The review didn't come up with anything revolutionary in terms of, you know, what kind of schemes are out there. I think we all know the contributory and the non-contributory system. So it was sort of a reconfirmation that the contributory, sort of the social insurance schemes, they are in low and middle income countries, and especially lower and lower middle income countries, very low coverage, and they're covering to a very small extent persons in the informal sector, and also parts of the formal sector, the low income earners, it's low coverage. Where it's coverage, it's usually complicated to get access to it. It's time limited. The benefits are usually quite small. Then you have the non-contributory schemes, which are often targeting the groups that are missing in the contributory schemes, namely the poorest. But if you look at the kind of entitlements that are included there, first of all, it's rarely actually taking aim on people with at least short to medium term sicknesses. So for example, COVID-19 would be not a qualifier for many non-contributory schemes. And even if you are, the entitlements there can be much less than what actually the income losses related to the conditions are. So I think a conclusion from that review in the context of COVID-19 is that coming into this pandemic, countries had very different starting points in terms of systems to tweak and build on to have a successful response, specifically now for income support and income security. Of course, most, say, for example, European countries, and I think South Korea is also an example of that, have quite advanced social security schemes. And I'll come back to that in terms of some experiences where I actually live and work. But we also did some analysis very early on in the pandemic, already back in March, and this was by one person in the research group that is based in Vietnam. And I think the observations there have also been sort of reconfirmed from many other places. And that is that even we heard about the social health insurance, which has been greatly and successfully scaled up, but it does not really cover income insecurities. It's not a sickness benefit scheme as such. Although some schemes exist like that, as in many other countries, they're not really covering the majority of the population for a condition like COVID-19. So it was rather clear that people that were put in quarantine, for example, did not have access to that kind of income security. So on top of any out-of-pocket expenditure for personal protective equipment, for accessing care, which was probably rather marginal. But when we heard from the Vietnam situation that the co-payments were brought down, and that was not the main issue. But compounding income loss due to quarantine or lockdown with the cost of being unemployed, which is an obvious one, and that brings us into the unemployment benefits. So implications of this, I mean, more broadly speaking, is that if you do not have a system that also covers for income security when you're sick or when you need to be put in quarantine, then it leads to, in theory, a couple of things. The first one is very obvious, and that is presenteeism. So the first rule of fighting COVID-19 is stay home, self-isolate when you're sick, when you have symptoms. And that is very hard to do, of course, if you do not have any kind of income security. The second thing is then if you're deemed either by recommendation or by law to be in quarantine, that is also very difficult to do if you don't have an income support system tied into it. And therefore, adherence, at least in theory, would be low. Of course, the same thing applies when you have to, maybe if you get more severely ill and you need to spend a lot of time in care, not only, including hospital care, it's not only the out-of-pocket expenditure then for that care, but it's also the time that you spend in care that you will not make any earnings. And that, from our tuberculosis research perspective, we've shown that it's actually the bigger part of the economic implication for patients and households is the income loss and not the out-of-pocket expenditure once you have a decent social health insurance that covers for healthcare costs. So there's also a conclusion that sort of universal health coverage and building social health care or medical insurance is only part of the solution, and you need some mix of universal health coverage and universal social protection, including sickness benefit schemes. Let me just end on a sort of a positive note. Now I'll take you out of your region and back to my region. I'm based both in Sweden for my work at Karolinska, but I'm also this year working actually on COVID-19 response in Finland, and a very affluent part of this country with a very, very well advanced social security system. Both in Sweden and Finland, there have been, like we heard from Korea, the possibility to tweak an existing system. So once you have a good system in place, you can do tricks to improve the COVID-19 response. And this includes, for example, taking away the requirement of a doctor's certificate before you can get your sickness benefit from day one. So it's just reducing the admin and reducing the need to go and seek care. Even if you're not diagnosed, this was actually taken out. If you have symptoms, you stay home to make it easy. Another thing that was done was to make it clear that it's not only if you're sick, but actually you're healthy, but you're a close contact. You will also get the same, actually you will get 100% of your earnings during the quarantine time. A third example is that it was introduced a new type of entitlements for people who were not exposed necessarily, but they were in risk groups and should self-isolate to reduce the risk of being infected. And if you had was a list of conditions, you would get a certificate, and you can actually for several months get, I think in this case, 200% of your income supported in order not to risk being exposed even to the virus. So we're not talking about close contacts here. So the success of that, I mean, it's too early to judge, but it's quite obvious, opportunities to use a social security system to improve a pandemic response, at least in theory. I think I'll stop there, Luis. Thank you.
Thank you so much. So you put the emphasis on the importance of income protection for workers to be able to adhere to treatment, to protocols, self-isolation, because indeed they have to forego income if they have to adhere to those protocols, and that is a problem. So the pertinence of income protection and also robust systems of comprehensive protection that can be tweaked to certain these epidemic periods. Marielle Fégoussat, she is from the ILO, and she also would like to stretch the importance of further reforms in sickness benefits. Marielle? You there?
Yeah, sorry, I was on mute. Okay. Good morning, everyone. Maybe I will start, if you allow me, with following the sharing of experience we just got from Dr. Knut Lönnroth. I would like also to share some experience from Asia on how the existing sickness benefits were adjusted to make the most of their existence and to broaden the scope of coverage. So acknowledging, of course, all the limitation in terms of scope of coverage that exists in the region. What we noticed is that thanks to all the benefits that sickness, all the advantages of sickness benefits, it's no surprise that sickness benefits were among the most widely used social security measures across all countries in the world, and Asia was not an exception. So when we look at all the social security measures that were taken, we see that sickness benefits represent about 30% of all these measures before unemployment benefit and waiver on social security contributions. So how countries in the region made good use of these sickness benefits to ensure broader coverage and better protection? First, by extending statutory coverage to workers who are usually not entitled to sickness benefits. So for instance, in Singapore, we saw that Singapore provided cash benefits to employees and self-employed who had to quarantine. And this is quite noteworthy in the case of Singapore, as in normal times, sickness benefits are the sole responsibility of the employer. In Fiji, the government provided once-off grants for workers in informal economy who tested positive. And a similar measure was also implemented in Vietnam, where a small grant was allocated by the government to people in mandatory quarantine, whether they were positive or not to COVID-19. So the first strategy was to acknowledge that the contributory sickness benefits were limited in coverage, and that the groups that are uncovered needed that same protection. Another measure taken was to extend situation in which sickness benefit can be used. So for instance, PhilHealth COVID-19 in the Philippines provided a comprehensive package mixing care and cash for workers in isolation to provide this financial support to people under investigation of COVID-19. In Myanmar, quite interesting, while the coverage of the population is extremely limited, the Social Security Board decided to expand the use of sickness benefits to pregnant employees, allowing them to take anticipated and longer maternity leave so that they are not exposed to COVID-19 in the workplace. We also observe in countries like Russia or Uzbekistan that governments increased in some instances the level of benefits, both in terms of duration and the percentage of income replacement provided to workers who cannot be at work because of sickness. Just like in Europe, some countries have also changed the rules to access such benefits. For instance, adjusting waiting periods, waiving these waiting periods so that workers can immediately access benefits without waiting for the income support to come in. So that was the example, for instance, of Australia, who has eliminated the 1 week waiting period for sickness allowance and other income support measures. Some other countries have opted for administrative measures to simplify access. For instance, Japan waived the requirement of obtaining a medical certificate for claiming sickness benefits. So these are just selected examples that show that while sickness benefits are limited in terms of population covered, sometimes in terms of benefits covered, it was among the first measures that the government took and adjusted to provide better protection to the workers.
Thank you.
Yes.
Thank you, Marielle. I think we need to wrap up this roundtable due to time constraints. I appreciate your input. Indeed, when such schemes were in place, it's much easier to adjust them and to face this crisis, this heightened risk of poverty through higher replacement rates and so on, better duration. And it's much easier to respond when speediness and rapidity is of essence than to set up new schemes where, for example, the issue of registering new people, designing, going through parliamentary processes take much more time. So the existence of a legal framework and the ability to redesign benefits and adjust the rules has been critical. Thank you for these illustrations of what Dr. Lundroth was saying before. Let me, I see there are not many chat questions. I keep the one that is there in store for if we have a little bit of time to the end. Please don't hesitate to ask the participants any question regarding this first round of questions and the next round that we have now. For this one, I would like participants to be even more succinct in responding, rather the speakers to be more succinct in responding to the second question. What is the impact of the crisis on the system? What are the priorities going forward based on the lessons that you've learned? Let me start again with Mr. Phikday Sambo from Cambodia.
Thank you. In terms of the impact of the crisis, what we see so far would be the reduction of the health services utilization because of this, social distancing, right? So, but at the same time, we also believe that because of the better hygiene, people tend to wash their hands more often, and the school will close, the kids stay at home. So these also the reasons why it leads to the lower incidence of illness. But we don't really see the bigger problem to the system, like I told you before, that we don't really have many cases. So, we don't see the big impact to the system so far, except for this funding issue. Of course, when people, they don't pay more the contribution, but they're still entitled to the benefit. So, but luckily that our health insurance fund was doing well. I mean, before the crisis, they had a quite substantial amount of the surplus. So during this time, I believe that they're still doing pretty well in terms of funding. But if the crisis continues, I mean, further, that would be another question to answer. And in terms of priority, I think during this crisis, the tax revenue, of course, would be reduced, right? So it is really difficult to expect more funding from the government. So because the government also had some other intervention, like I said before, the COVID cash transfer relief and so on. So during this crisis, we believe that the only thing that we would need to focus more on is the efficiency, of the system, because based on our experience, that we can see that almost any system in the world, we face of this problem of inefficiency in terms of implementation of the health system and also the health insurance system. So with this, I would say that it is the good opportunity for us to to focus more on this. How can we improve efficiency in the system, and of course at the same time without compromising the health of the population. So thank you.
Mm-hmm. Thank you. And of course, the low incidence of illness and the sort of the prevention aspect is also a way to make, you know, to prevent escalating costs during the epidemic. So thank you for highlighting the fiscal long-term consequences of the epidemic. Let me give the floor to Dr. Nguyen Can Phuong.
Hello. Yes, I'm here. Hello.
Yes. So what would be the impact of the crisis in Vietnam in terms of the health system?
Yes. The impact of the pandemic can be clearly observed on the health system, especially and in general, and on the social and health insurance expenditure as well. Firstly, we can see that due to the pandemic, the utilization rate is reduced, especially the utilization at the higher level, at the central or the provincial level. So the cost of the total expenditure of the health insurance member for the medical care is reduced significantly. However, on the other side, the revenue of the social health insurance also decreased because of the unemployment situation increased. In Vietnam, we have the 5 groups of the health insurance enrollee. The first group is who work in the employee and employer. So the second group is the one who pay by the social security, like the pensioner, and the people have the social subsidy monthly. And the third group is those who totally subsidized by the government, including like the poor, the elderly, and the children under 6, and the minority, ethnic minority. And the fourth group is those who partially subsidized by government, such as the near poor, who subsidized by government 70% of premium, so, and the student who subsidized 30% of premium by government. And the last group is the household member who not belong to any other group. So because of pandemic, so the many enterprises have been closed because of economic close. So the many people lose their job, or they have to go to stop working because of the isolation or quarantine, and then so and also the people lose income because of that. So there's the collection of revenue for social health insurance certainly reduced because of this. So the pandemic has the impact on the social health insurance, both sides, decrease of the revenue, but also the decrease of expenditure. But that we also can observe some the gap in the coverage of the significant health insurance fund during the COVID. During the COVID, we increased the application of the technology with the apply of the telemedicine nationwide to increase the access to the healthcare for people in need. So up to now, the government has have the more than 1,000 telemedicine points nationwide. But now the health insurance still not pay for costs associated with the telemedicine. There's no the legal framework for payment, for paying those the new type of the service delivery. So from the under the pandemic, that also needs to revise, to adjust the regulation, the legal framework, so that the health insurance can make the use, the maximize the coverage of health service and financial protection for people under the scheme.
Thank you. Thank you so much. So you emphasize basically the need, the need that was there to adapt the financing modes to the ability to pay, and also the need going forward to include other services, telemedicine in insurance, and to expand further access, particularly those who are far from central services. So let me give the floor to Mrs. Hee-Trung Kang.
Hello, I'm here.
Yes.
Yes. Yes, in relation to your request, I want to introduce our government announcement last July. It was about Korean New Deal. In the Korean New Deal, they insisted very strongly about the safer society. I'm sorry. Anyway, we've learned important lesson from this pandemic. Is that safe society is a denominator for promoting all other advancements. And the problems surrounding temporary position and vulnerable workers is the main cause of polarization in Korean society. So in the New Deal, because of in the New Deal, the safer society was included. And one of the policies to realize that the safer society, sickness benefit was specified in the report. By the report, anyway, we are preparing to introduce the sickness benefit in the NHI program from 2020. And so we are designing how to introduce the benefit schemes into the NHI program. So we will perform the demonstration from the next year. So, but anyway, there is many challenges to handle that. As you know, to include more benefit in the NHI program, we need more financial burden. So maybe, as you mentioned, our social insurance is based on monthly based premiums. So we have to levy more premiums to all general public. So maybe we have to make a consensus to give some more burdens to the public to make some public fund to sickness benefit. So especially according to the government's plan, from 2020, the sickness benefit will be applied only for the low-income workers, maybe such as non-sterile workers. So maybe for them, most of the financing will be given by the public fund. So as you know, to make the public fund for them, every general people have to pay more tax to the government. So and then from the initial step, anyway, it will be enlarged for all the insured of the NHI program. So in case of that, we have to make a more consensus to levy more premiums to the insured to realize social solidarity. So anyway, most of them is not easy one to handle. So I want to share your experience from now on keep on that. Thank you.
Thank you. Thank you very much. That's really a very practical takeaway from the crisis, the need to have sickness benefits under collective funded systems. And particularly, you mentioned the problem of low-income workers who are not protected. We mentioned, of course, sickness. To have that in place allows one to be prepared for the next crisis and be able to respond quickly. Of course, we mentioned that those sickness is mostly for short-term spells. I have not seen anybody talk about this emerging evidence that there are also maybe chronic effects of COVID. Maybe this is something for the future to think later on, improving the other types of benefits as well, such as invalidity and others that may take after the sickness benefits, but that's for the future. We have little time. Dr. Runroth, maybe in 1 or 2 minutes, your takeaway.
Yes, thank you. My takeaway will be global level and more conceptual. I think the COVID-19 pandemic has shown, and all these great examples that we heard, that we need to look at, and I'll keep the focus now on sickness benefit. It's only one part of the pie, but it's really important, and I think it's a neglected part of the pie, that we need to look at sickness benefit not only as a way to alleviate economic impact of diseases or accidents. It's actually a tool to enhance access and adherence. So whenever we talk about health insurance, we need to at least consider, does sickness benefit figure there? Whenever we talk about universal health coverage, we need to consider, is sickness benefit included there, or is there a clear link to any universal social protection thinking in the same space? And finally, and this is something that, as you know from ILO, we wrote a piece on this together, that in the SDG framework, sickness benefits are not really clearly and transparently spelled out. And there is no indicator to follow the coverage of sickness benefits. It's relevant both under SDG 1, of course, but it's also relevant for SDG 3, the one on health. And if we don't have a global framework that captures this, I think we will lose an opportunity to build on the good examples that we have now. Countries are doing things, a global framework needs to follow that and then reinforce the things that need to happen on country level. And I think that's something that we need to make a joint effort on. And I think this is a global crisis, but it's also a global opportunity to push that agenda forward. Thanks.
Thank you very much. Very clear recommendations. Marielle, 1 minute.
Yes, I'm coming last, and I don't want to repeat what has been said earlier on. So of course, the priority now is to reform the system to build what we always call the shock responsive systems. We have mentioned the key element, extending legal coverage embedded into law, particularly through reforming the financing mechanisms, because the crisis has shown that the sickness benefits and the way they are funded is not neutral when it comes to provide coverage to all. So we have talked about moving away from employers' liability and the need to move to collectively finance sickness benefits, be it through social insurance or public taxes, but also considering social assistance to call for more generalized measures for income support in time of crisis like COVID-19. We just mentioned also the importance of improving the coordination between healthcare and sickness benefits. The point has been made very clear just now, so I'm not going to dig into that. But I would just add also the need to improve the coordination across social protection systems. They are often fragmented, and that must be overcome to ensure a continuum of social protection interventions that include healthcare, sickness, unemployment benefits, social assistance, and so on, to ensure that everyone can receive the income support needed on time in such crises. So we'll just stop here. Thank you.
Thank you very much. We made it almost on time. I am thrilled to have had the opportunity to moderate this roundtable. we have one or two questions. Unfortunately, there's not a lot of time, but let me just take this one. I mean, how concerned are you that some critical illnesses may have been crowded out? I mean, care for those illnesses, chronic illnesses, attention to maybe chronic treatment for cancer, or other vulnerable groups may have not been paid attention to during this crisis. Maybe from Vietnam or Cambodia or Korea.
Yes, I think it's very important to keep up existing expansion of NHI coverage. So this crisis could not crowd out the other diseases importance. So although we are responding to this COVID-19, in the other ways, we are trying to expand our coverage of NHI in the NHI program for all the diseases, as we planned.
Mm-hmm. Indeed, it was an expansion that can benefit other diseases. You mentioned telemedicine, that can be used for all diseases.
Yes, in Korea also, as you mentioned, disputes about telemedicine have been ongoing, but as you know, there are many arguments about introducing of the telemedicine in the existing healthcare systems. It's about the privatization or liberalization of the public healthcare systems. Maybe there are some concerns about that. So anyway, it's very important to using those kind of technologies into this healthcare system to advance our outcomes, health outcomes. So anyway, we have to keep up with this kind of technologies merged into our system.
Okay, thank you so much for everybody's contribution. And thank you for the audience for this. I am tasked to say that coming up next is a clinic on preparing our social protection sector for future shocks in times of COVID-19 and beyond, working alongside the humanitarian sector. So I know there was a specific question on this. Maybe you can take it up in this next session. And also there will be a roundtable for all the people's livelihoods and social protection. So thank you. Just a note from my side that you can access 2 podcasts on sickness benefits and healthcare responses from Marielle and from another colleague, Emmanuel Saint-Pierre from ILO. It's, if you type or if you Google China, ILO, EU project on universal social protection, like this, you will be directed to the site of the project, and you will be able to see there are 2 interesting 20-minute podcasts on this particular topic for you to, just to continue the conversation. So thank you very much, and keep well and continue with the global conference. Thank you very much.